Monitoring the physiological status of a patient under anesthesia is incredibly important to have a successful induction procedure and recovery from anesthesia. Most animals are going to be hooked up to monitoring devices such as an ECG, an echocardiogram that can have blood pressure monitoring with it as well. But understanding what those values mean and how they correlate with the planes of anesthesia and how your patient is responding to the procedure are vitally important as well. First two that come to mind that are, could be the most critical are heart rate and respiratory. Is my patient breathing? Is my patient's heart beating? The ECG, most machines will be able to tell you, they'll give you a number, they'll give you a heart rate, which is beats per minute. They will also show you the ECG, the electro part, to show you the rhythm. Normal sinus rhythm is what we want to see in our patient with a nice, strong, steady heartbeat. Changes in that can indicate problems with our anesthesia or with our patient. Some of the things that you may notice with the heart rate are changes in the actual rate. You have something like bradycardia, which is a nice slow heart rate, which can be indicative of an anesthetic level that is too deep. You can have a very high or tachycardia, which can be indicative of our patient being too light. This also occurs in the first planes of stages of anesthesia as the patient is going under. You find, high to high norm or normal to high normal heart rates. During anesthesia, you want a nice steady heart rate and a normal rhythm. Some animals, particularly dogs, can have a sinus arrhythmia where the rhythm changes during inhalation and exhalation. Anything other than that should definitely be brought to the doctor's attention. Things like an AV block, a first-degree AV block, may not be heard on just the normal beeping sounds that the ECG machine makes. So that's why it's important to have a rhythm, a visual aid to help with that as well. Respiratory rate and rhythm is also important. We want our patient breathing, obviously. There are different parameters as well. Tachypnea, rapid breathing, can be indicative of a patient that is too light. Can also be indicative of complications with the actual anesthetic machine or the intubation. There could be difficulties moving air. So these are also things that need to be aware of. Low breathing or can also, a low respiratory rate can be a patient is too deep, meaning we need to lighten up the anesthetic. We need to give our patient a breath. We can definitely need to be monitoring the rate and the patterns and with that as well. Those are the two main systems, physiological status systems that we monitor. But again, we have different monitoring equipment to understand our patient. Mentioned blood pressure. Many machines are built in with a blood pressure monitoring device. Blood pressure is useful in determining perfusion to our tissues. A lot of times during anesthetic procedures, our perfusion, our blood pressure tends to lower. We compensate that with IV fluids, but it can also help us judge the rate of, whether our planes of anesthesia are proper. If our patient is, our blood pressure is too high during a noxious stimuli, that is another indicator that our patient is responding to that painful stimulus, so we should increase our anesthetic depth. If our patient's blood pressure is too low, could indicate that we are too deep of an anesthetic level. We should decrease our anesthesia. And if we are at a point where our blood pressure is too low and our anesthetic level seems appropriate, then we may need to increase our fluid rate to compensate. Anything lower than 60 millimeters of mercury, I believe, is where our tissues start to suffer and the perfusion is too low, and we can cause some tissue damage, particularly in the kidneys. Other parameters that we can use to monitor that are more visual aids are the actual physiological status of the patient's self. You're going to check things like the mucous membrane color. So, our little friend here, you would lift the lip and you can check along the gum lines. Mucous membrane colors, although it's not the best parameter for measuring perfusion, it can be shown, you can see changes that hopefully you would notice prior to the actual change in the gum tissue colors, but conditions such as cyanosis, where you're getting a lack of oxygen through the blood, you'll notice bluish, grayish colored gums. So our mucous membrane color would change there. You would also notice a decrease in our pulse oximeter. That should also be a part of your ECG setup. You should notice that first before you even get to the point of having those bluish tinged gums. It's not the best parameter for perfusion, but it is definitely one that can be used. CRT, or capillary refill time, is another parameter that you can measure on the gum line or the gum tissues. Again, you would lift the lip, just gently apply pressure and release, and you're going to count how long it takes from the blanched white to return back to its normal color. We want a nice pink, ideally less than 2-second capillary refill time. A slow capillary refill time can be indicative of blood loss or, again, poor perfusion. Another parameter that you can be checking that kind of coincides with our blood pressure that we mentioned earlier are peripheral pulses. Sometimes the blood pressure machines are not available, so you can check a blood pressure by ideally using other types of machinery, but you can check pedal pulses. So usually they're on the plantar and palmar surfaces of the paws, and generally it can be hypothesized that if you can feel a pedal pulse with your fingers, then your blood pressure is above 60 is basically what that general is. So that is another way to measure that. Also, you can check peripheral pulses to make sure that they are equal. That is can be for a heart rate rhythm. You want to check femoral pulses, both in the insides of the rear legs. You can check those as well. The monitoring of your physiological status of your patient should be done every 5 minutes. You're going to be checking these changes, monitoring depth, how they're reacting to, the stimuli, the surgeon, versus your changes in the body and everything. Other status things that you can check on your patients are the presence or absence of reflexes. As they go through varying stages of anesthesia, the presence or absence of reflexes change. For instance, you have the pedal reflex, which is also called a withdrawal reflex, where you're going to, on the paws, you can apply pressure. Ideally, it's a significant amount of pressure, but they should have basically a deep pain response where you apply that pressure and they're going to pull back. That is really helpful when you're masking down a patient using just, not a chamber induction, but a mask induction, because you're going to miss some of the other parameters that are more visual on the face because the mask is covering them. So that is one parameter. Another one is the ear flick parameter, where if you touch their ear is going to twitch. That is generally lost pretty early on in early stages of anesthesia. Same thing with the pedal reflex. It will be present in light anesthesia. Medium, it's usually lost by that time. And if your patient is too deep, they will not have that reflex. Another reflex is the palpable reflex or the blink reflex. And that is where you will touch the patient on the either medial or lateral canthus. And by just gently tapping there, that should cause their eyes to blink. That is, again, present in light anesthesia. That reflex generally fades as they transition to a more moderate plane of anesthesia, and it is absent in our deep planes of anesthesia. Another one is the corneal reflex, where, again, you will gently touch the eye with something sterile, like a cotton or a drop of saline, and their eyes should retract. Again, gradually decreases as you get deeper and deeper into your planes of anesthesia. The swallow reflex is another measuring tool that you can use. It is definitely present in an awake animal. It's that reflex of when something touches the pharynx, they automatically, the epiglottis closes and they want to swallow. This is very common in cats, even after induction. They have very sensitive larynxes, and so as you go to intubate, intubation can be difficult because as soon as they feel that touch of the tube, the ET tube, or the stylet, whichever you're using, that epiglottis tends to close and those vocal folds close, making intubation difficult. Hence the reason lidocaine can be sometimes dripped back there to aid in your intubation process. The swallow reflex is also important during recovery. That's going to be one of those reflexes that will slowly return, and you want that reflex to be present, strong and present, before we remove the ET tubes from them. Usually a good 2 to 3 good solid swallows before we remove the tube from them. This is very important for any kind of surgical procedure where aspiration could be an issue, even after post-dental procedures where there could potentially still be some fluid from the dental cleaning still in the back of the throat. You definitely want them to swallow versus aspirating if you remove that tube too long or too early and they go to swallow and it goes down the wrong tube. Jaw tone or even muscle tone itself is another parameter. It's not the best parameter to use for anesthetic depth, but again, goes through the stages. The more alert, light the patient is, the more rigid their jaw is going to be. So the more difficult it's going to be to hold the patient's jaws open in order to intubate. They're going to struggle. Should be nice and slack, or should be nice and loose, but not completely slack during your moderate planes of anesthesia. If you are too deep, then there is no muscle tone. That jaw is loose. There's no, it just flops for you. And we definitely know our patient is too loose then. One of my favorite anesthesia monitoring reflexes or statuses of the patient is eye position. When they are light or in the very beginning stages, their eyes are going to be central. The pupils themselves will probably be constricted. When they are in a good medium level of anesthesia, their eyes tend to be in a caudo-ventral. They tend to be pointed down, slightly medial, but more just, pointed down. So when you lift up this top lid, you're going to see the majority of just the whites of the eye. And that is a good indicator of anesthetic depth. If they are too deep, then their eyes tend to be fixed, central, and basically that patient is staring right back at you if they're too deep. And their eyelids, or their pupils tend to be dilated. So we definitely know we're at a too deep of a anesthetic plane. It's really important to use all of these different monitoring devices, whether you have the equipment available or just your own eyes, ears, and hands on your patient at all times, just to make sure that you are monitoring and changing things appropriately. You're alerting the doctor when you need to. If things have changed on our ECG, there's an abnormal rhythm that needs to be addressed. Our patient is not breathing on its own regularly, so we need to bag him more often. There's definitely all sorts of things that you as the anesthetic technician can address, catch, correct, bring attention to the appropriate personnel to fix, to make sure that your patient has a nice, smooth transition from induction to procedure and a nice, smooth recovery, and that our entire anesthetic protocol or procedure goes the way it is supposed to.